Today I'd like to demonstrate two different ways to take a George Gage bite. This is Mary. She is our patient today. Mary has recently tested positive for obstructive sleep apnea and is elected to treat this condition with an oral appliance. The laboratory requirements for an oral appliance are upper and lower models and a protrusive bite. While this video will not demonstrate the impressions for these models, full upper and lower impressions would be needed. We use an alginate substitute like DMG's Status Blue due to its firm consistency, it's reportable, and easily disinfected. Today we will demonstrate two methods of obtaining protrusive records using a George Gage. What you see here are the materials required. A common mistake I see when dentists take a George Gage bite is assuming the patient is going to close into the bite fork exactly like they normally close into centric occlusion. And what I see in my practice is exactly the opposite. Most patients have a tendency to deflect to the right or left when closing into the fork. I'm going to demonstrate how you might alleviate this problem. I like to use cheek retractors for this next step, but they are certainly not mandatory. You will need to mark the midlines of the patient's face in centric occlusion, and a Dr. Thompson's marker works very well for this. Cheek retractors make it easier for me to discern the midline. With Mary, you can see the midline of the upper centrals is in line with the facial midline, so I will not need to mark anything for the upper. The lower, however, is not, so I will mark that with a Dr. Thompson's marker. Now that we have our midlines, the next step is to take the lower unit of the George Gage and fit it over the lower centrals. Take the white 5mm bite fork and place it into the George Gage. Be sure you line up the middle of the white block with the upper midline, which is the midline of the centrals in Mary's case. Now you want to check the interocclusal space to be certain there is adequate room to allow for the thickness of the appliance you have chosen, and in Mary's case, this is a dorsal. We see that there is more than enough room for this, so I'm going to check with a 2mm bite fork next. With the 2mm bite fork, everything is going to be done the same. Place the bite fork into the George Gage, place the bite fork into the mouth, line up the central block with the midline of the centrals, have the patient close. Now check the interocclusal on the side. We can see here that there's plenty of room for a dorsal appliance, so this will be the bite fork that I will use in Mary's case. I also want to make sure that her central incisors are able to bite all the way down into the V shape. Here you can see they are, so this bite fork is going to work fine in this situation. Now we'll take protrusive records. You want to have the patient protrude as far as possible and back to CO. Move the jaw as far forward as possible again, back to CO. Do this several times. On the third time, I will usually hold the maximal protrusion, take the bite fork out of the mouth, tighten down the thumb screw, and just see how far they can protrude their mandible. A lot of dentists like to use measurements and go 50, 60, 70% of maximum protrusion, and that's where they want to mark the bite at. I prefer to set the bite at a position I think is more comfortable for the patient, place that in their mouth, make sure that their muscles can tolerate that, and that's where I want to set the bite. Bite fork is set, we can take the bite registration. Impression material, wax, or bite registration can be used for this. I will be using O-Bite bite registration for DMG. Always bleed the tip before applying. This material is perfect for this situation due to its minimal bite resistance, which allows a patient to completely close into the George Gage bite. When applying to the bite fork, you will notice great stability and staying in place on the fork, which allows me to slowly extrude the material without developing any type of air pockets. It also has superior break resistance, which is necessary for the lab to accurately mount the models. After filling the fork, place it into the patient's mouth and center with the upper midline. Have the patient slowly bite into place. While this would look like an excellent bite registration, unfortunately this will have to be redone due to the patient deflecting to the right upon closing. However, notice the detail with DMG's O-Bite bite registration. Here is a much simpler way to take a bite registration for those patients that have a tendency to deflect to one side. Place the bite fork in the mouth and center with the upper midline. Have the patient slowly close, and again, we can see this patient deflected off to one side. Hold the fork in place with the upper midline. Slowly have the patient move the mandible until the lower midline lines up with the center of the little gray block. Once again, we will be using DMG's Obite Bite registration. This time we will inject the material directly between the teeth. Be certain that the George gauge and the bite fork are properly aligned with the upper and lower midlines. Now inject the material between the teeth on both sides. Due to the flowability of this material and its superior break resistance, I am able to inject an adequate amount of material between the teeth. Be sure the patient is biting firmly into the George gauge so that there is no lateral movement. This will assure that the upper and lower midlines are aligned correctly. Once the material has set, remove and check that there is sufficient amount of material to properly mount the models. When you compare the two bites, both are very accurate, yet the one on the left would need to be remade due to the patient deflecting the lower jaw on closing.